Thank you very much for the organizers for inviting me to this beautiful conference. It's the first time I join a team of dermatologists and talk about my experiences with regards to the oral mucosal diseases. So the topic is an overview of the dermatoses that can present in the oral cavity. I have no actual or potential conflict of interest related to any part of this presentation. However, I do give the acknowledgement to the institutes where I work currently and I worked previously for the cases that I'm going to present during this presentation. So I currently work at the University Hospital Sharjah as a consultant. I work also at the University Dental Hospital Sharjah, part of the University of Sharjah, as a professor in oral medicine. And previously, my training was in the Royal Melbourne Dental Hospital. And the cases that I'm about to present are a combination of the three locations. My apologies for the voice. I'm losing my voice over the past few days. All patients presented in this presentation have given their consent to use their clinical images for academic purposes. So I'm going to give a brief presentation on my specialty in case some of you do not yet know the content of oral medicine. And then I'm going to give some examples of how the oral cavity works as our window to understand the disease or to diagnose various systemic diseases. So to start with, oral medicine is sort of a blend of dentistry and medicine. Oral medicine specialist does not deal with the teeth or the dental pathologies, but rather with the head and neck pathologies in general. The majority of our work relates to mucosal diseases. We also see orofacial pain cases, salivary gland disorders, and medically compromised patients. It's almost 100 years old, and the majority of the initiation of that specialty started in the United States. However, today, most countries in the world, they recognize this specialty, and there is a pathway for fellowship and board certification for clinical specialties. The majority of the cases that we see are mucosal pathologies. The second will be the orofacial pain. Among those mucosal pathologies, the most common ones are the erosive and ulcerative lesions. And studies in different parts of the world have shown that oral mucosal changes, whether they are pathological or reactive, are quite common. At any time, 10% of the population, 1 in 10 people, will have some sort of mucosal disease of various severity and various clinical significance. In general, those pathologies can be divided into erosive, ulcerative, blistering disorders, red and white or pigmented lesions, and masses or lumps. So for the sake of organizing this presentation, I have divided the talk into the following 5 categories. So first, we'll be talking about the variations of normality and the reactive lesions. Those are common. They can be mistaken for a pathological change. So we have the Fordyce granules, which represent ectopic sebaceous glands. We have the leukoedema and the racial pigmentation. Sometimes lumps can also be a variation of normality. This is an example of an ectopic thyroid gland that was referred to me with the suspicion of lymphoma or malignancy in the root of the tongue. Thyroid function was normal. However, the ultrasound of the neck did not show the thyroid gland at all in its anatomical place. Lesions can also be reactive, that are a response to low-grade irritation, physical irritation, which can be from the teeth, or it can be from the calculus or some food particles, and this can lead to a transient or chronic pathological changes, but they are still reactive and reversible upon the removal of the lesion. Some are chronic, persisting, and they have the potential to transform into malignant lesions, such as the use of smokeless tobacco, characterized by poorly demarcated white lesion, sometimes with erythema, and unfortunately, this can progress into squamous cell carcinoma at the exact site where the smokeless tobacco was placed. Moving on to the microbial infections, the oral cavity is very, very rich in microorganisms. There are more than 700 species living there. It is only second to the GIT. And what characterizes the oral cavity is the availability of various niches. So we have the teeth, we have the cavities in the teeth, we have the periodontal ligaments, and so on. And this allows the diversity of the microorganisms to live there. I'm not going to talk about dental infections, but everything else. So the most common, obviously, is the oral candidosis, and it is characterized by some pseudomembranous changes with an underlying epithelium. Please don't treat oral candidosis without understanding or trying to investigate the predisposing factors, because pseudomembranous candidosis can actually be a representation of an unknown or undiagnosed case of immune suppression. This could be AIDS, could be blood dyscrasias or leukemias, could be undiagnosed diabetes, and so on. So the treatment of oral fungal infection or oral candidosis is not difficult. It is achievable with topical medications, but the importance is to understand the underlying causes. Another important and common microbial infection is the herpes simplex virus. In this case, this is the primary herpetic gingival stomatitis, also commonly mistaken for some throat infection or some also candidal infection, but it is not, because it's characterized by the superficial erosions and specifically on the keratinized part of the oral mucosa, not the non-keratinized part. So we don't see it on the cheek mucosa, we see it on the dorsal tongue and the gingiva, hence the term gingivostomatitis. Reactivation of HSV is known worldwide to be on the vermilion border of the lip. And that is true. However, what I have seen in the past few years is that there is a lot of cases that are referred to me, and it actually represents reactivation intraorally. Same thing, vesicles, superficial vesicles that rupture very quickly within hours, followed by multiple superficial ulcerations. What is unique about that is the unilaterality. We hardly see them bilateral on both sides because obviously of the track of the trigeminal nerve. Another virus is HPV, and Dr. Sherlev has already touched upon that, and the presence of HPV infection. Obviously, verruca vulgaris is common in the skin, rare in the oral cavity. Most of the time, the one in the oral cavity actually represents an autoinoculation. The other one is the condyloma acuminatum, or HPV 6 and 11. Again, most of the time, it is sexually transmitted. It could also be an autoinoculation, so from the genitalia to the oral cavity. Another microbial infection that we can see in the mouth and can be problematic is the Treponema pallidum. In this case, we have this patient in the center of the palate. She had no skin lesions, but had this solitary mucosal lesion on the palate. No known clinical attribute that can be given clinically, and a biopsy was needed, which showed rich plasma cell infiltrate. Immunohistochemistry panel did not show that this is some form of malignancy, but suggested syphilis, and she was actually positive for syphilis on the serology. Next, I'll move on to the immune-mediated lesions, and in our practice, the most common one is the oral lichen planus, characterized by the striation, reticular striations with an underlying epithelium. You know, my immediate advice for those patients is if there is any metal on their teeth, to replace them, to go back to the dentist and ask the dentist to change those metal restorations. Here is an example of a patient who had oral lichen planus, biopsy proven. The left side of the cheek was completely healthy, the right side of the cheek was manifesting lichen planus, and it's only the right side of the cheek that had the metal fillings, or the old rusted or damaged metal fillings. Sometimes lichen planus can be quite problematic to the patient because of the pain that it will generate, and those are usually associated with the erosive subtype of lichen planus. And the erosive subtype of lichen planus is the one that has been associated with the malignant transformation. So those patients need to be monitored very closely. Sometimes we need to take multiple biopsies throughout the years in order to make sure that no dysplastic changes are taking place or even neoplastic changes. This is a case of an old lichenoid lesion progressing into mild or moderate dysplasia. The patient is still under observation. So another form of an immune-mediated case is the lupus. Again, those are patients who present early in the mouth. Lupus is peculiar for its palatal involvement. The palatal erosion is peculiar in those situations, and it is surprisingly disproportionate. The pain is disproportionate to the appearance. So you look at the appearance and you think this must be very painful, and it's actually not. There is also the spontaneous bleeding that those patients will be complaining of. That's the SLE. Another patient that presents also early in the mouth, few weeks to few months before the appearance of the skin lesions, and those are the patients of an autoimmune disease. So this is a case of only with the stretching, only with the examination stretching, attempting to take a biopsy under local anesthesia, and this is what you get. So the tissue is really sloughed off, very fragile lining of the mucosa, and this is obviously the pemphigus vulgaris. There is a common saying in pemphigus vulgaris, and all autoimmune diseases in general, or vesicular bullous diseases, first to show, last to go. They are recalcitrant. This is the oral component. So the skin lesions might take months to appear. When they appear, they are easily controlled with medications, but the oral component of pemphigus vulgaris or the other vesicular bullous autoimmune diseases usually is stubborn. It takes a lot of time to control. Another example that we also see in the mouth, which is the mucous membrane pemphigoid. And here we have the blistering disorder. It is less severe than pemphigus. The bulla itself is actually tense. The wall is tense, so you can still see it. Please pay attention here that most of the time pemphigoid, mucous membrane pemphigoid, appears in the gingiva before anywhere else. So it has some sort of preference to the gingiva, and here in this image you can still see the blood-filled blister. And of course, another is the linear IgA disease. This is a unique video here because the blister was intact, and even upon my manual examination, I was still able to, the blister had the dense wall to maintain itself. So this is an example of another situation. You must have seen it in the dermatology. In the oral cavity, it is extremely rare. To be solitary in the mouth is also extremely rare, and that's the autoimmune progesterone. In your case, dermatitis. In our case, stomatitis. No problems if the patient presents with the allergic reaction in the skin in the form of dermatitis, but if there is an absence of the skin lesions only confined to the oral cavity, then this would be quite unique. And in fact, there was only one case report presented in the past. Another form of immune-mediated lesions affecting the oral cavity are the swellings or the granulomatous changes, whether it is allergic angioedema or orofacial granulomatosis. So in the last 2 minutes, I'm going to show you a few examples of neoplastic changes. Of course, oral squamous cell carcinoma is considered to be the most common oral cancer that we see. In the mouth, we see a number of cancers, but the most common one, 90% of the time, is squamous cell carcinoma. Despite the fact that it is there, right in front of our eyes, it is not hidden cancer, it is not hidden in the GIT or in the internal system, but the prognosis still continues to be poor for those patients because of late diagnosis. This is an old study, back in 2010, retrospective study on the stage at diagnosis for oral cancer patients. I'm sorry I didn't find any updated studies to show you, but this is the one that I have. And unfortunately, most of the patients are diagnosed in stage 3 and 4. Why does this happen despite the fact that it is right there and visible in front of us? Probably because of the overlap with other benign lesions, other common lesions, such as frictional keratosis, lichenoid changes, and so on. The ulcers are very common, but some of those ulcers actually represent squamous cell carcinoma. And lumps are also common, pyogenic granuloma or fibroepithelial polyp or simple irritational fibroma, but some of those polyps are actually squamous cell carcinoma, and attention is needed for those. Same thing with the color changes. We see the rarely malignant melanoma in the oral cavity. This is obvious that it is a pathological change, severe pathological change, but we see pigmentation as well in the oral cavity all the time. Unfortunately, most of those patients, when they come to me after a number of visits to the pharmacies and to the other doctors, GPs, dentists, and so on, and they're given to, they are given a diversity of topical and systemic medications to try to solve this problem. So we have a problem with the diagnosis. There is a delay in the diagnosis, unfortunately. Oral vesicular bullous diseases are usually diagnosed 8 months after the initial presentation. MMP more than 12 months after the initial presentation. This is based on recent data and in other places. Oral cancer is diagnosed after 2 to 3 medical consultations. This delay in diagnosis, whether it is a vesicular bullous disease or an oral malignancy, has a detrimental effect on the patient and will affect the prognosis. We have a problem with the pharmacists who are dispensing the medications based on the patient's verbal complaint, and that also results in a delay in the diagnosis. I just exceeded the time, so I thank you for your attendance and thank you for the organization one more time.